Hi, everyone. I'm Dr. Bitner from True Women's Health, and
I'm Dr. Celia Egan from True Women's Health.
hello, everyone. We have so much to get to tonight, so without further delay, I love this topic that Dr. Egan came up with, steamy summer, and how do we call it?
Steamy summer, your blood sugars, and your intimate health.
Perfect. I love it. And it's just such a perfect combination of each of our backgrounds as an OBGYN and expert in menopause and sexual health, and then
I'm an internal medicine doctor, and I have a special interest in weight management, obesity, blood sugars, nutrition, sort of all that stuff. And I think it's really fun. This really great overlap of our fields, I think, has been super fun to sort of explore and figure out different ways that we can sort of help women.
And what's so crazy is that my world, in terms of GYN, menopause, sexual health, has never crossed over or talked to the world of obesity, metabolic health until Dr. Egan and I serendipitously met almost 3 years ago. So This is really exciting.
And vice versa, right? So the obesity medicine world, we talk so much about testing blood sugars and thinking about exercise when we never even think about sex and sort of reproductive health and menopause. And so it's just so fun to sort of have both of the spaces together.
Agree. And, it's like, I don't think tonight is necessarily going to give anyone the magic pill or magic, knowledge about how to totally improve their sex life or fix their diabetes or fix anything. But I've really found in talking to women, if they just have some information to know why, then it is so powerful to make even small improvements. It just moves that needle more and more closer, more close to what you want. So I'm really excited to have this conversation.
Yeah. And I sometimes think too, from my space, sometimes it can feel overwhelming to be like, oh my gosh, I have to lose weight. And how many women out there have tried to lose weight? And so sometimes it can be really freeing to leave that idea of saying, you know what, who cares about a number? Maybe I just want to improve my sex life. And there's things that you can do that even just of that being a goal could actually make your overall health better, and maybe you'll lose weight in the process. And so sometimes it can be helpful just to shift focus from something that maybe can feel so defeating to something that maybe can be a little more inspiring and obviously a little bit more fun.
And I think it's also thinking about, what is sex? Does sex mean penetrative intercourse? Doesn't have to. Sex is intimacy and pleasure. And so if your back hurts and you have self-image issues that you don't want to get fully naked, it doesn't have to happen that way to have sexual pleasure. So having said that, I just want to bring up, what is the definition of sexual health? And I'm going to read it a bit because it's from the World Health Organization. And it doesn't mean the absence of disease. Like, sexual health just doesn't mean you don't have a STD or, again, a disease. Sexual health is the state of well-being in relation to sexual health and allowing a respectful approach with a possibility of having pleasurable and safe interactions. That's cool, right? So it's all about, being able to have pleasurable interactions between consenting adults and having it be a really good thing that helps improve quality of life. And in a lot of the research that's done around this, they talk about sexual health, quality of life.
Yeah. And I think even in my space, being an internal medicine doctor, even before I got sort of more involved with obesity medicine, I would say the majority of the times we talk about sexual health, it's mostly like sexually transmitted disease screening. And we think about, young people and sort of screening for STDs, but it's so much more than that. And I think a lot of women in middle age kind of feel forgotten in this arena because they're like, well, maybe I'm lower risk for STDs, so who cares? And that's just not true.
No. And we know that sexual dysfunction, there's a really high prevalence. And we know that younger women have better desire, but might have pain or bladder infections that interfere. Women who are older, let's say, 80 plus, might have less distress about having low desire, but there's more dysfunction. So it's just, kind of a ballpark number is about 70% of women have some level of sexual dysfunction in their life. And we physicians have a sense of that, but only about 20% of physicians will bring up the question of sexual health with their patients, even though we know, again, a high proportion. Women, only 20% of women will bring it up with their physicians because either they've been blown off in the past, because, again, most docs aren't comfortable talking about this. So, again, we want to get the conversation going.
Yeah. And so and let's switch gears a little bit to think about kind of how I think about things in my obesity medicine world. And, the term in particular that we're going to talk about is what we call metabolic syndrome. So a syndrome is sort of a collection of symptoms that we don't really have a great pathophysiology behind. And when we think about metabolic syndrome, it basically is a subset of criteria. So we're thinking about high sugars, a large waist circumference, so a lot of adipose tissue at the waist, and not necessarily a total body weight, but really focusing at that extra adipose tissue or fat at the waist and at your tummy, so waist circumference. Changes in your lipids or your cholesterol levels. In particular, we're talking about triglycerides, which is one type of lipid that our liver makes, and then having a lower what we call HDL, or it's traditionally been called the good cholesterol, though that name's sort of fallen by the wayside as we've learned more about it. But that being low, triglycerides being high, and then having hypertension or having high blood pressure. So one or two combinations of some of those things would put you in the category of having metabolic syndrome. When I think about this syndrome, I basically think your body is not handling energy appropriately. So the foods that you're taking in, particularly the sugars or carbohydrates that you're consuming, are just not being handled appropriately by your body. And one of the things that can happen is you store weight in inappropriate places, your liver's spitting out the wrong combination of cholesterol levels, your liver's repackaging the glucose back and spitting it back out into your blood as being high sugars. And we know that in general, metabolic syndrome can lead to chronic disease that none of us want. Vascular disease. Go ahead.
I'm so
vascular
sorry.
disease, cancers, dementia, all these sort of big things that we're really trying to avoid.
So this is huge and so important. What kind of symptoms do you see from women who have all of these things, metabolic syndrome?
I think the big thing that we see is that women come to see me for is weight gain, right? Tummy weight gain, their pants feel tighter. A lot of the times, we do aggressive screening here at True. So we're able to talk about some of those things that we see in lipid levels and blood sugars, maybe much more than other doctors would look at, particularly women at a younger age. When people have high blood sugars, a lot of people women talk about feeling bad, feeling tired and fatigued. Some women talk about going to the bathroom too much because all that sugar in the blood sort of forces water into your urine, your kidneys. And so maybe you're peeing a lot, maybe you feel a little thirsty. There's sort of a variety of combinations of things, but a lot of the times women will talk just about feeling not well.
Mm-hmm. Yeah. And even just, that fatigue and two, I think about what I've read about fat being deposited in the muscle tissue, which just drives the whole process, right? And I would imagine that has something to do with fatigue.
Yeah, some of the latest research on this is super interesting in terms of where does this all begin? Again, this is a syndrome. We're not 100% sure. It's not set in stone exactly how these combinations of things happen. We think a lot about the muscles, a lot about the liver, and those are some of the targets of treatments that we talk about, whether it be lifestyle changes or medication treatments.
Right. So this kind of, what this brings to mind is a patient I took care of years ago, and she talked a lot about how she had low desire, and she also had high blood pressure, diabetes. She had high cholesterol. She had a lot of belly fat, and she just didn't have a lot of sexual desire. And it really started to be an issue in her marriage. And so what probably made it worse was she wasn't getting any sleep. You know why she wasn't getting any sleep? Is she was making herself stay awake until her husband fell asleep because she didn't want to be in the bed with her husband, because then she'd have to have sex and it hurt and she didn't want to do it. And she set her alarm to wake up before he would wake up so she didn't have to be in the bed with her husband. So he was mad that she was never in the bed. They didn't have sex, and she felt worse. They were arguing more. And she's like, please just help it not hurt. Then at least I could have it and I don't have to fight about this. And maybe I could actually get some sleep.
Yeah. And we talk about that snowball effect, right? Where, the more she probably wasn't sleeping, probably the less she was able to make good food choices, right. The less she was excited about maybe exercising, probably the worse, more of the wrong food she was eating, sure. More fatigue she felt. Now her blood sugar is feeling worse. Now she feels less likely to do these things. So it just kind of creates a little bit of that snowball. And
low sleep makes more insulin resistance, right? So it's just, it's crazy again, how just one thing leads to another. And, I remember we started vaginal estrogen, we treated her bladder infections, and she started, at least it didn't hurt. So she negotiated a time to have sex. So now she was sleeping back in the bed every night. She was getting more sleep and she felt better and everything was getting better. So, it's just helping one thing can then snowball to the benefit.
And I think that's why we sort of embraced how this has to be a conversation, right, around sexual health, is because if you don't have, as a primary care doctor or a physician, you're not able to have this conversation, you're really not able to get at the root cause of some of the reasons why people are limiting their ability to make better lifestyle changes. Again, I always will talk to patients. I mean, I can tell you till I'm blue in the face all the different things to do, but the reality is a lot of women know what to do. There's other things that are preventing them from getting there, of sort of making some of those choices.
Yeah, I mean, if she just had said low sex drive or something, or if I hadn't asked her, I might never have been able to uncover the fact that she wasn't even going to bed on time, or she wasn't going to bed. She was getting like 4 hours of sleep. Right. So to your point, we've got to ask those questions. And a lot of docs will say, well, I don't want to ask the question because I don't know what to do with the answer. So, that's a problem. And I was fortunate enough to get some good training, and it's made me a lot more comfortable. And you've always seemed very comfortable talking about it. But again, I think the more that we can, all boats rise, we can create education to make that happen.
Yeah. And I think it's such an exciting time because I think there's more and more understanding and tools for physicians to have to sort of have that conversation. And at least there's other tools for patients to at least go to kind of learn on their own.
Exactly.
So in thinking a little bit more about what is the overlay between sexual health and sort of having metabolic disease. So one place that we've already talked about is the liver. So if you think about after we eat something, the next step for a lot of that food is it goes to our liver. And then our liver is trying to process, sort, and organize sort of what we've eaten. The other thing that our liver does is it really helps organize some of our other, either make and organize some of our other hormones. So as you can believe, if you're not eating the right things, or if you're headed in a direction where you're have this mismatch of energy balance, sometimes the offshoot of that can be that our liver isn't making and producing the right hormones. And we see that a lot kind of with patients who are struggling with metabolic syndrome. I mean, one thing that's sort of an overlay of that is PCOS, or polycystic ovarian syndrome, where one of the thoughts is maybe that there is a blockage in the way that our liver is handling some of the body's ability to sort of absorb some of that extra estrogen that's made. And younger women struggle with, some of the other symptoms that come with polycystic ovarian syndrome.
Well, and from a gynecologist standpoint, I've always been taught and think about PCO. It's not an ovary problem. It's a liver problem. It's an insulin problem. Correct. And insulin sort of clogs up how the ovary gets messages from the brain. So the ovary is making estrogen, but it's not making enough progesterone. So there's not ovulation. So all this extra estrogen then gets stored in the belly fat. And so it gets converted to estrone, testosterone. It creates more hair growth, more cystic acne. And so I've always been taught about it from that direction. And then which just perpetuates the problem, right? Like there's more belly fat, there's more insulin resistance, and it goes on and on. So, it's a big deal.
Yeah. So one of those overlays, when you think of trying to be like as a direction, if you want to improve your sexual health and your overall metabolic health, one sort of target is sort of looking at the liver and maybe trying to use some medications that, if we really believe that that was a problem, would be something that we would target. And so there's a lot of medicines that we use in our office. One particular would be like metformin, which is, helps basically shift the way that our liver processes sugars and can be really helpful of getting blood sugars back to normal, either if you have something like type 2 diabetes or even like a pre-diabetes.
Right. Well, I just think of another patient who had polycystic ovarian, right? So she had very spaced out periods that were really heavy. She had extra hair growth on her face, on her sideburns, on her breast, on her belly. She had a lot of belly fat, and she wanted to get pregnant, but she didn't want to have sex because she felt very uncomfortable with her self-image. She was very tired. And so I said, okay, what we need right now is to help get your health back in order. And so long story short, we used an IUD for control of her periods, protection of her uterus, to keep her uterus safe from all that extra estrogen. We used spironolactone to block her hair follicles, so it really treated the hair growth and the acne. And then also we were able to use metformin, which then helped treat that insulin resistance. And she was able to lose some weight. She was counseled with increasing her muscle mass and a healthier diet. And she was able to lose even, 10 pounds. She didn't have the hair growth anymore. The acne cleared up. She was able to lose a little bit of weight. IUD came out, spironolactone was turned off. She stopped using that. It can cause birth defects. And she was able to want to have sex and got pregnant. So again, I always wanted to be an OBGYN who knew about medical stuff. And I just love how you're very interested in sexual health.
Yeah, and I think that's such a great story of proving our point of this overlay of thinking about, blood sugars, our hormones, and how our body's sort of processing and shifting and trying to make all those things work. And somehow they can go a bit awry if there's different lifestyle or different circumstances that shift it in a different direction.
100%. So I want to talk just a smidge about, we've talked about the definition of sexual health, but then, what do people say when they come in? They say, I just don't want to have sex. I don't have libido. I don't have drive. It's too hard to have an orgasm. It's too difficult because it hurts. So we talk about low desire, either low spontaneous desire, where women just don't think about sex. Partly I think just their body has shut that part of themselves down because of distress over the issue. It can be hormonally related. It can be related to a history of pain. And again, or I can't have an orgasm anyways, why even go there? Or it's responsive desire where there's a certain cue. Maybe it's a certain song comes on, or it's Friday night or Sunday morning, or your partner's like, hey, sex tonight? And the response is, no, I don't want to go there.
Yeah.
So we look at those two different kinds of desire, and it really, again, I think helps people have that language.
Yeah. And do you find, I've been told, and I'm sort of curious what your thoughts are, that the spontaneous desire over time maybe sometimes goes away, and maybe it's not necessarily normal, but feels more common. Would you say that that's accurate?
It can be definitely related to estrogen. So especially it goes away over time, midlife, menopause. And a lot of times spontaneous desire comes back when women can or choose to use estrogen medication. For women who have, let's say, low testosterone, we know that testosterone also plays a big role in spontaneous libido. And so, again, with aging, with midlife and menopause, that can be an issue. And for some women who choose to take testosterone, that can really help that spontaneous libido come back.
Yeah, I know this is a sort of a side topic, but I think the world of testosterone replacement in women, I think, is only going to expand. And I think the data of understanding testosterone's role in women, of course, we don't believe in taking big boy doses. That is never a good idea. But finding that sweet spot with testosterone replacement is going to be a really interesting conversation as time goes on.
Yeah. And we follow the International Menopause Society guidelines. And so anybody can Google them, IMS Menopause Society guidelines. And it talks about level 1 evidence, which is, randomized controlled trials versus level 2 versus anecdotal or, individual experience. And we look at replacing that with FDA approved testosterone in very small doses and monitoring blood levels to make sure they're safe. So again, at True, all of us are very comfortable with that and keeping those levels below 70. If the levels go above 70, we worry about high LDL. We worry about anger, anxiety. I had a patient who came to us who had gotten the pellets and her level was 400 and she was having hair thinning, hair growth, and she was angry and her family was like leaving for the weekend because she was so scary.
Yeah.
Of course, she wanted to have sex all the time, but there were a lot of side effects that weren't good.
Yeah. And I think what women sort of fear is that we won't be able to fix, or we'll basically ignore a lot of the symptoms of low sex drive and, all the things that come with menopause, like hot flashes, unless you do pellets, which I don't actually think is true.
No, exactly.
Yeah.
And what I was just thinking about is, again, you talk a lot about body positivity, which I love. And, I think about one of the treatments for low responsive desire is something called sensate focus. So it's a type of sex therapy that focuses on the sensation. So again, just what the word means, but it's using non-sexual touch for a couple to reconnect. And I remember I asked a patient, part of her reason for low desire, and she's like, I'm just not comfortable with my belly fat. It makes me feel awful. And during sex, if he touches it, I'm done. It triggers me she used the word fat. I feel fat. I feel unattractive. It just reminds me. I'm like, did you ever ask him just to not touch your belly? And she's like, well, no, I didn't think of that. And so she said, hey, I'll have sex if you don't touch my belly. And he's like, that's all I have to do is not touch your belly. Okay. And so they were able to pay attention to other areas. And so they didn't have to, so it kept her engaged. So it just made a big difference.
Yeah, I think it's just so, and we talk a lot about this in my space of, trying to understand cravings and desires for food and alcohol, which tends to be, big drivers of getting your sugars out of whack. And I think, women are just so busy doing so many things for so many different people that it's really easy to forget to focus on our bodies. And then when we ask it to, I don't know, get ready to go, have sex, it is a big ask, right? If we're not thinking about our bodies all day and then we're doing all these things for so many different people. And then all of a sudden we're like, all right, body, like, let's go.
Right.
It's just give your body a little bit of a break and maybe just reconnect.
Well, we know too that it takes 30 seconds for a guy to get aroused, right? It takes 30 minutes for a woman to get aroused. And so what I'll recommend a lot of times is women out there, women with men or women with women, like you initiate the encounter on your schedule. So then you don't have to do it on his, I'm right. Stereotyping to men, but you don't have to have it on his schedule. So, when you're tired and you'd rather just not. So
or any partner who is quick to arouse, right? And maybe you need a little more time. That's okay to take a little bit more time. That's not abnormal. Yeah.
It's okay to have a quickie in the morning and then you don't have to at night when you're tired.
Yeah. So in thinking about some other aspects of sexual health, I find that unfortunately for a lot of the overlay of metabolic health and sexual health, a lot of the studies are done in men. So we want to just show a little bit of the anatomy. And so, we love anatomy just because we're doctors. So forgive us for showing kind of some pictures, but we're going to show kind of the similarities between the anatomy of a penis, which is the male genital organ, and a clitoris. And even just looking at an overlay, they kind of look a lot alike, right? In the way that the nerves and the blood vessels sort of are at the top part. And then there's a whole sort of vascular system underneath. Obviously, I've spent less time, sort of hands-on as this is Dr. Bitner has, but, I find it just so fascinating. And when we think about, getting aroused, a lot of the times that's an influx. So particularly for men, it's an influx of blood to these, genital areas. And there's been some really interesting studies, again, mostly in men, just because that's where a lot of our research dollars go. But I think we can sort of translate some of that to thinking about, women's sexual health. But in men, what they found, which is so interesting, is when men are struggling with erectile dysfunction, so a lack of an ability to sort of stimulate the penis, or there's a lack of blood flow to that region, a lot of the times they're finding, even at the first episode, that these men have undiagnosed diabetes. And they found a really high proportion of those men who are struggling with some erectile issues also were struggling with blood sugars. We find that same thing sometimes with male infertility, meaning that male sperm just aren't moving as well as they should. And a lot of the times we find that they're having undiagnosed metabolic or sugar issues that come into play. So if we want to translate that to sort of women's sexual health, one could argue that, if you're struggling with blood sugar, sometimes there can be a decline in the way that you're getting blood flow to these special regions. And then just sort of getting aroused and having an orgasm just is harder and more difficult. And it should always be a conversation with your primary care doctor if this becomes something new, because it may be a sign of some other, part of your life that's just not working as well, and a more of a time to maybe start some sort of other medications or have more advanced lifestyle changes to change some of your metabolic health.
Right, because a lot of women will talk about it's a lot harder to have an orgasm, but as you see from this picture, some of it certainly can be mental, it can be emotional, it can be distraction, all those other reasons. ADD is something that can really inhibit an orgasm because your brain is thinking about 20 different things. But blood flow is a big part of it. That's why orgasm can be difficult in menopause, because there's not blood flow down there because of lack of estrogen. And to your point, with blood vessel dysfunction, high blood sugars, then the same thing happens. If there's not blood flow down there, the clitoris has to get erect in order to drive arousal, and for all the neurochemicals to get released, and for the brain chemical response. This all has to, again, it starts with that clitoris getting erect, and we need blood flow for that to happen, just like the penis gets erect.
And I think, why is diabetes so dangerous? So one of the reasons is the way that it interacts with the lining of the the arteries, or that's the tubing that supplies the blood to all of our organs. And that lining is really sensitive. And if you have these high sugars, what can happen is the lining gets all these nicks and basically gets clogged. And that's what vascular disease is. Of course, we talk a lot about this at the heart, or what we call the coronary arteries, or the piping to the heart. And we worry about heart attacks. And then if we go further up, we think about strokes, which is the blockage of the blood supply to the brain. But your clitoris is just as important to protect. And so, if we really, are thinking about this and thinking about our blood sugars, one reason that you could really be excited to get healthier could be just to protect your clitoris. And that's totally a good reason.
Well, you've taken care of men. I haven't, but just in conversations, like if a guy knows like, oh shoot, I just need to lose 5 pounds. I need to get my blood sugar under control. I bet the conversation would be much more powerful if you say, your A1C is 6.5, and if you can get it lower, that will protect you from having erectile dysfunction.
Well, you'll laugh. Some of my patients will laugh because we do have conversations about, if we're trying to make good food choices and our partner really doesn't want to, right? Meaning they're bringing home donuts and they want to go have pizza every night and they want to do all these things that we really struggle in those situations. And they're, losing weight maybe isn't their main driver, and living longer maybe isn't a real driver. I always mention that their penis will work longer, and sometimes that's enough to kind of get things going.
Exactly. Well, when you first started talking about metabolic health and sexual function, I kind of thought you were going to go to the brain, because I love the connection between the same, my obsession with peanut butter. So, certain foods give the same pleasure that an orgasm does. And there's a lot of research about that same center in the brain of satiety. And one of our favorite colleagues and friends, Dr. Jim Simon, actually protected the term the masturbation diet because of how sexual pleasure can mimic the same satisfaction from food.
Yeah.
So,
and I mean,
I don't know if we're promoting the masturbation diet, but there's something to that.
Yeah. And I think that when you think about, why we make food choices, right? Sometimes we make food choices because we're hungry, right? Our belly's empty. We haven't eaten in a while. We need some fuel. But a lot of the times we're doing it for that reward sensation, right? I want peanut butter. I want a cookie. I want a crunch. I want popcorn. I just want something at this restaurant. And that wanting, right, is the same as you're applying the same reward center that can be sort of activated with, sexual desire. One thing that's kind of interesting is finding that balance of reward can sometimes be hard, because if you're in one spot where you're getting a lot of reward from maybe alcohol or too much sugar, then sometimes that desire to then just have sex as a reward doesn't seem as good. And, I know one of our sex cars can be thinking about excessive alcohol use as something that can maybe drive, lower sex drive.
Really good point. Which brings me to what do you want, right? So if people say, I want to have an intimate relationship with my partner, I want to have a good sex life, prove it, right? Let's really look at what's important to you and make decisions. And knowing that your history, let's say with alcohol or with sugar, that's a barrier. It's not an excuse. It's not I don't know what a better word is. It's not an excuse. You don't have to feel shame about it, or you don't have to feel bad about it. It's okay. It's a barrier. It's a bad habit. It's something that's not healthy for you. If you can really get in touch with what you want, then we can sort of use that knowledge of what's been a barrier or blocking you in the past, and use that as a way to get around and get forward on your path that you want to be on.
Yeah. And one of our big conversations in sort of our weight loss world that we talk about at True is, your cravings for sugar, your cravings for alcohol, they're not you, right? Your hair color is you. Your eye color is you. That's you. Cravings are what's happened to you. It's from the foods that you've eaten. It's from some of the subliminal messaging that you've had. It's from some of the experiences you've had growing up and what you've been told to turn to. It's not you, and it doesn't always have to be that way. And so you can do a lot of work, either cutting back, making changes, meditating, adding in exercise, getting on different medications to make that journey a little bit easier to change some of those cravings. And so just letting go of this is me forever and it's never going to change. That's just not true. And you really can make some changes if you have some goals that you want to achieve.
I love that. And I just want to bring up the sex deck, because I was kind of scrolling through some of the literature that I've read before just to see if there's anything new. And again, when we look at sexual dysfunction, let's say obesity or metabolic syndrome, it's all about, again, not only blood flow and metabolic parameters, but like depression. We know that women who have depression and anxiety have lower sexual drive, maybe more sexual dysfunction. And so again, it's looking at all the different cards. So the sex deck is something that I came up with because I'd sit in these lectures about sexual health. And, some of my favorite mentors, Dr. Kingsburg, would like go through all the reasons for low sexual desire. And I'd be like, how am I going to remember this? And this has been such a good tool. Used it in the office a couple times today, because people say, either my desire is decreased, my arousal is decreased. So we pull this out and it can be really helpful. So it just goes through all the physical reasons. So we talk about the physical reasons of, let's say, incontinence. We know that women with diabetes and obesity have more incontinence. And, it's not always pleasurable to have intercourse or have sexual intimacy if you're afraid that your bladder is going to leak or, heaven forbid, the rectum leaks, right? So incontinence can be a big issue. Low estrogen and low testosterone, again, can happen. We talk about hormone variations with PCO, with liver dysfunction, but with menopause. And maybe if someone is not being treated for midlife and menopause, in part because of maybe inappropriate fear about use of estrogen with moderate obesity, then, low estrogen can be a real issue. I think one, Celia, you wanted to make sure we addressed was the card about depression and anxiety and how that relates.
Yeah, I mean, I think there's more and more research that's coming out looking at, maybe eating the wrong things, particularly consuming a lot of just simple carbohydrates or free sugars, and mental health. That's a big topic sort of in the weight loss world, of these overlapping themes that we're seeing. And we know more and more that just basically simple carbohydrates or just simple sugars can really drive more feelings of anxiety in particular, but sometimes hopelessness and feelings of depression. And maybe if you're someone who's prone to having those symptoms, that it just would be enhanced with sort of eating the wrong things, and the higher your blood sugar may go. If you're feeling crappy, whether you're super low, feeling super down, or you're overwhelmingly anxious where your mind is just sort of spinning on thoughts, that never puts anyone in a good sort of place to be ready to have intercourse. And it's really hard to connect with somebody, a partner, when you're in either one of those places.
Exactly. And two, I think about the relationship of unresolved life events. So you're worried about your weight, you're worried about not being able to get pregnant, you're worried about, you're worried about heart disease, and you've already got some calcium in your blood vessels. When you're worried about these unresolved events, it uses up all your brain chemicals. So there's not enough for fun. What I'll say to a lot of women is like, sexual desire a lot of times comes up, pun intended, when everything is good, like you're on vacation, so in the busyness of a regular day, then you're not thinking about sex. But you go on vacation, everything is okay, like bills are paid, vacation's paid for, we're isolated from usual stresses, then all right, let's have sex. So again, if you're worried about all these other things, about your health, so it's just really important to make that worry list, get some things down, and then look at and see how can I get some resolution on these issues.
Yeah. And it's just so interesting how, the different foods we eat can really impair our ability to move from one thought to the next. And so even just the ability to say, I'm really worried about my bills, for instance, let's just say, being able to move from that thought of, but here's my plan that I'm going to do. I'm going to do budget all my money, I'm okay. That one next step of, one foot in front of the other of problem solving is difficult to do sometimes if we're eating the wrong things in our, particularly, like I said, simple carbohydrates, that continues to further perpetuate that spinning sort of thought thread that our brain will have.
Right. Or a patient was telling me, she's like, it's just so crazy. She said, the kids are out of the house. I thought we'd have this great sex, but it hurts. She wasn't on estrogen vaginally at the time. And she's like, we come home from work. He's tired. I'm tired. We're both overweight. We have our pasta and our salad, and the TV's on, and we're both asleep by 7:30 in front of the TV. She's like, this doesn't feel very sexy. So we talked about how, yeah, it doesn't sound very sexy. So what do you want to do about it? So then it was, okay, we're going to go for a walk right after dinner. Okay, we're holding hands, we're walking outside, we're laughing, we're talking, and then we get home. So I'm like, okay, after dinner, do not sit down, do not turn on the TV. Just that simple little change. And they started interacting because, one of the sex deck cards about interpersonal is insufficient intimacy. And so if you don't have that fun, like you said, fun intimacy, but also that physical activity after eating. If I ate pasta, I'd be asleep in the corner. And so, as you've taught me, if we have a treat, we go for a walk. So the blood sugar's going up, we go for a walk, blood sugar comes back down, it's in normal range. Now we have energy. Now there's energy for sex.
Yeah. I definitely think sitting in front of the TV is a hard sell on sex. I don't know how many people are really excited after pasta and Netflix.
Yeah. Especially if there's snoring involved, right? So, and of course, sleep apnea and snoring, that's a sign of obesity, of diabetes, of metabolic syndrome. So again, it's like, whatever it is that's bugging you, that's going to trigger like, okay, it's time to get a handle on this. And again, just a real quick thing, feel free to ask questions. If you're too shy to ask questions on this live forum, feel free to DM us after this, and we'll get to your questions on the website or on the Facebook page, etc. I wonder if we could talk about this all night. I'm having so much fun. I don't know about you. This is good.
I love talking about this stuff.
Do we want to get into our tips and tricks and questions?
Yeah.
I can't believe we've already been chatting for 36 minutes.
Yeah, let's do some tips and tricks. So
we always like to, say, what are the 5 takeaway tips? So of all this conversation, how do you want to move forward and think about this? So I think about, what is your picture of self? How do you want to be in terms of your sex life? How do you want to be in terms of how you feel about yourself as a sexual person, a sexual being? How do you want to think about your relationship with your partner, if you have a partner, and whoever that partner is? Like, what does that look like? What is the impact on your life? How do you feel about just having ease? So it's having intention and having a vision of what that looks like. You can't get there if you don't know what that is.
And I just want to clarify for everyone, this is not us saying you have to have sex. Right? We are not saying that, because I think sometimes that can be the message that people take away, and they feel like it's just one more thing to do on their checklist. That can be totally fine to say, you know what, I'm okay not having sex right now or never. That's everyone's choice. But I will say a lot of what I hear in my office is that's not what people want. People want to do this, right? And that bothers them that they can't, or are struggling finding this right next step. So I think it can be okay to even think about this in that capacity.
100%. I've had patients say to me, well, if I don't want sex and he doesn't want sex and we're holding hands and we're comfortable, is that okay? I'm like, of course it's okay. It's only a problem if it's a problem and if there's distress associated with it. So for example, we talk about hypoactive sexual desire disorder. It's only a disorder if there's distress. And so really good point.
Yeah. And I think too, as you said in the first part of our talk, everyone believes that sex is just intercourse, right? That does not have to be the case. You can still be intimate without necessarily having intercourse. And part of your picture of self maybe it's not intercourse, maybe it's something else that's being intimate, and that's okay too.
Yeah. I love the book 8 Dates by the Gottmans. And one of the 8 dates or 8 critical conversations is around intimacy. And there was some really great language in there in terms of, let's say your partner wants to have sex and you don't for now, or maybe for a longer time. Like, how do you talk about that? How do you talk about that without hurting the connection or hurting your partner's feelings or having them take it personally? So it's just, how to have language around that. So I can't recommend that book enough.
Yeah, that's great. All right. Tip number 2, take a deep dive into your blood sugars. I mean, we obviously at our office, we love looking at blood sugars in many different ways, whether it's looking at what we call your hemoglobin A1C, which is the average blood sugar, over, 3 months, whether it's doing a CGM where you can look 1,000 times a day, doing a bunch of different things. We love looking at this in a variety of different ways. And if you're someone who's concerned about this, talk to either your primary care doctor, or obviously if you're one of our patients, we'd love to sort of talk with you about this. And I think it's, something that everyone should have a good sense of where their blood sugars are at.
Just saw a patient the other day. She was using a continuous glucose monitor because, she was having night sweats and she was on a good level of estrogen. She was working out a lot. My theory was that she was having low blood sugars during the night, which triggered a stress response, which then would create a night sweat. And that's exactly what happened. She had a CGM on. Her blood sugar would peak after dinner and then it would go down. And then the rest of the night it would be up and down. And she would have the night sweat when she had the low blood sugars.
Yeah.
And so it's just really fascinating. And so she added a little farro or a very high fiber complex carb at dinner, just a small amount, more protein. She had a cheese stick before she went to sleep. I hope you agree with that, Celia. And her blood sugars evened out and she didn't have night sweats anymore. So it was just awesome. I mean, it's a big deal. And if you don't sleep, you're not going to want to do anything fun. So
yeah, totally. All right. Number 3. Oh, we were just talking about this. Some of the new technologies to figure out some of your lifestyle choices. So again, a lot of us know kind of what we should be doing for some of our lifestyle stuff. I always make the joke. No one's ever like, oh, Dr. Egan, thank God you told me donuts aren't great for me. I mean, everyone knows what to do, but how do you do it? Whether maybe it is wearing a continuous glucometer and kind of getting inspired about controlling your blood sugars. Maybe it's using, a mindfulness app to follow some of your cravings. There's a lot of different ways to sort of use new technology to sort of help bring down your barriers.
Well, I was talking to Mitch about weight loss and then I listened to a podcast that you recommended, but more and more about zone 2 of heart rate, right? Mm-hmm. Where we could do a physical activity for hours, but we can talk, but we're getting sweaty. For me, that's a heart rate of about 130. And I use my new technology, right? My Apple Watch to tell me when I'm in zone 2. And that's been really helpful in terms of thinking, okay, I need 90 minutes a week, according to Mitch, of zone 2 to really help me to lose a little bit of weight. And just having that steady, it's been an awesome thing. So I get on the bike and do a nice steady ride.
Yeah. And one of our favorite things about new technology is really getting new exercise classes to people. So, we're big fans of just the Peloton app, just because it's a really cheap, easy way without having to buy the bike, to just have different classes that are focused on different things, whether it be strength training or yoga or some cardio classes. And there's a bunch of different programs out there now that really are bringing some sort of expertise to people's homes, which is really exciting.
Love it.
Yeah. All right. Number 4.
I think we've talked about this a lot, but yes.
Just remind everyone there's this connection, right? And that, maybe your blood sugars being off could affect your sex life. And if your sex life's off, maybe something's up with your blood sugars, and fixing all of it can be, add years to your life, most likely. So there's that connection.
So a patient the other day who lowered her A1C from 6.4 to 5.5. And I just said, amazing. Oh my God. You started on metformin. That was her choice. And she felt better. She felt this window of opportunity. I'm just like, oh my God, you've added years to your life. And not just years, but good years.
Yeah, good years.
She was very excited.
Good years to have more sex.
There you go.
All right, number 5.
You are worth it. So I love the data around women who cope well with hardship. And one of the things that has to happen is you have to believe that you deserve to be happy. So we believe you are worth it. We hope you believe you are worth it. We have 2 great therapists if you want to talk about that more. But when desire or function is low, it's not your fault. Again, it's like cravings. There might be something going on. There are real factors that play a part, and you deserve to know what those are. So this is wordy about, please don't suffer in silence. Please know that it's worth the conversation. Sex is not anything you've got to be afraid to talk about. I used to be afraid to talk about it because I didn't know anything. And now sometimes I have to put the filter on. I'm so comfortable talking about it.
Yeah. And I think that whether it's, sex or trying to get your metabolic health in order, you should do it for you. And a lot of people come in, they want to do it for their kids or their partner. It's totally fine just to say, I want to do this because I want to feel better. I want to have more sex.
I love that.
Cool. Yeah.
There you go. That's cool. All right. These next questions are things that if you don't, if you're not in the state of Michigan or you're not able to see us at True, we want you to be able to ask your healthcare provider these 5 things.
So as I'm going to give this one because I feel like this is my favorite thing that I've learned from working at True is making sure that all women know and providers for their female patients know what their phase of ovarian function. So whether it's, struggles with sexual health, struggles with blood sugar, struggles with weight, you need to know where a woman's at in terms of her phase of ovarian function. And every woman deserves to know kind of where they're at. And you should ask your primary care doctor sort of what their thoughts about where you are as their patient.
Love it. I was on Fox 17 this morning talking about migraines in midlife. It's just like so many things peak when hormones go crazy. So it's so important to know where your hormones are at.
All right. Number 2. Has my blood sugar been thoroughly evaluated? Obviously we've talked about this. There's different philosophies about this. I would say we're a little bit more aggressive in terms of looking at blood sugars because that's sort of our experience in our knowledge bank. Not every doctor sort of does extra blood sugar testing, but if you're having some symptoms, as we've looked at some of these studies, albeit a lot of men, but everyone, if you're struggling with some sexual health stuff, you should have your blood sugar evaluated and make sure that, and I would argue it's beyond just a one-time fasting blood sugar. There should be some other evaluation if you're not feeling well.
I can't tell you all the times, even as a gynecologist, right, that, we check an A1C and CMP on everyone that comes in, and there'll be a normal fasting, maybe it's 89 or 90, but their A1C is 6.0 or 5.9. So it's just, or their fasting blood sugar is high and their A1C is normal, but it's still, it needs to be addressed.
And I think I would argue that there's probably even more aggressive physicians that are even looking at even more thorough testing. And that will probably be something that plays out over time as we get more and more research to support doing sort of some other
like
testing.
The oral testing, oral glucose
Yeah.
testing.
So what we call oral glucose testing, which is where we give you sugars and then we watch both your sugar and insulin levels over a period of time. And that really is really a much more thorough evaluation of where you're at. It can be a little bit difficult to do because you're doing these on cue, you're drinking sugar in our office and it's like a 3-hour test, but, and we're not quite there yet of being mainstream, but that's probably something coming in the future that will be part of sort of our wellness program.
But what's funny is like, as an OBGYN, if a woman had diabetes in pregnancy, it was something that we looked at year 1, at year 2, at year 3. And before I started using A1Cs, before I met you, I was ordering 75-gram glucose tolerance tests on women because I was taught that A1C really didn't tell us as much. And then I read a couple papers and heard people talk that an A1C was probably similar. But I just love how this is just becoming more and more refined with new research as it comes out.
Yeah. And I think it's so interesting because, I think what I love about our office is we're really giving women a place to be in midlife. I had another patient of mine had said, when you're in your 30s in that reproductive phase and you're having babies, like you feel so like cared for, like we care so much about your blood sugars when you're pregnant. Right. And we do all this testing and then all of a sudden you're like not pregnant anymore. And it's like, all right, goodbye. Right. And who cares? And it's like, well, you care. And there's other things that are happening. And we just love that we can provide this space where women can come and get some answers to some of their questions and really make sure that they're being thoroughly evaluated.
Well, in terms of being evaluated, if you had diabetes in pregnancy, make sure that you ask your provider. I especially need to be tested because I'm at very high risk. If you had preeclampsia or high blood pressure in pregnancy, you're at very high risk for premature heart disease and dysfunction of your blood vessels. So it's super important, again, to have that evaluated in terms of your metabolic health. So again, if you're not being asked those questions, please take ownership and ask for that.
Yeah.
Number 3.
Am I a candidate for medications to help with my sexual health?
You want me to talk about this? You want to talk
Yes,
about
you know more than medications than I do.
You know a lot too, but there's now 2 FDA approved medications for sexual health, and they're both approved for what's called hypoactive sexual desire disorder. And what that means is that even if you don't have factors that let's say low estrogen. Let's say you have low estrogen and low estrogen is resolved because you decide to take a hormone medication, but you still have low sexual desire. that can be from what we call hypoactive sexual desire disorder. So it's where we think a switch in the brain is just switched off. And there's 2 medications that are now FDA approved for this. One is called Addyi. It's a distant cousin, let's say, of Prozac, or it's a serotonin modulator. And it was studied for depression, and it wasn't shown to help much with depression, but it helped a lot that the women who were taking it were horny. So it's now used for low sexual desire. It's called Addyi, again, Addyi, and it's a daily use drug that's taken at night. So that's something that we're very comfortable prescribing, and it works for about 60% of women who take it. The other drug that's FDA approved is a drug called Vyleesi, which we have nicknamed the horny shot. It is a medication that works on the melatonin system, not in terms of skin coloring, but I'm saying it wrong, melanocortin and oxytocin, which is that bonding brain chemical. And so the shot Vyleesi is a shot that's given, and it within 45 minutes, generally there's very high desire. I tease women, they're going to be chasing their partner around the room. So warn them, even though a lot of women say that men don't warn them when they take their little blue pill. So make sure you warn your partner. But then the thing to know is it usually lasts for about 12 hours. So we did have a patient call and say, worked great, but I don't have time for this. And it lasted for about 12 hours, and she had to have sex several times in the night, and she needed her sleep. So, I'm like, where do you want to go with this? Like, what do you want? But these medications work very well in the right instance. And we're, again, very comfortable prescribing these medications. So please feel free to ask any one of us, Suzanne, Dr. Egan, or myself, and we can. But again, if you aren't able to see us at True, make sure you ask your doctor about these medications. And again, they're a really good, safe option. And there's more medications coming down in the pharmaceutical pipeline. So stay alert. It's good.
All right. Number 4. What resources do you have to get my blood sugar under control? So maybe you need to see a dietitian to learn a little bit more education about what, making better food choices would mean. Maybe it's seeing an integrative behavioral program to help control cravings and impulse control. Maybe it's using some of the medications that are FDA approved to help control some of your blood sugars, or to kind of work on your weight. There are a lot of resources that are out there. And if you're struggling sort of making different lifestyle choices, particularly in the dietary realm, you should reach out to figure out what to do next.
Love that.
All right.
And what resources do you have to help improve my sex life? Again, I would start with the sex deck. I mean,
yeah,
these are the 27 reasons for low desire. And all of these cards cover a lot of what we talked about tonight. And on the front of each card, again, is what. So let's say poor self-image. On the back is why, and more about it. And then what do we do about it? So again, this is awesome in terms of helping improve your conversation with yourself and really exploring what is the issue. And then being able to talk to your physician about it, being able to talk to your partner about it, to your best friend about it. Had lots of fun with, this at Girls Wine Night. It's pretty funny. Lots of great conversations. But it's just, again, a tool to get talking about it. So we raise awareness. There's also, we're able to connect, at True, but there's lots of resources out there in terms of sex therapists. And, someone who's involved, if you go to the website of ISSWSH, ISSWSH.org, or there's a website called Prosayla, Prosayla. It'll be in the chat on the side. But prosayla.com is a patient-facing website powered by ISSWSH that provides a lot of good sexual health information that is all evidence-based, and it's written in a way to help give women more information and help find them more resources.
One of my favorite things about the sex tech, which I know you've said before, and I've heard you talk about patients, is I think it's a great way in particular to have a conversation with your partner in a way that's not, tearing down someone's ego, right? A lot of the times when someone says, I don't want to have sex, then it's like ears are closed and they automatically are assuming it's because of, lack of, either attraction to themselves. And so it can be really helpful to sort of say, no, I really have some concrete things here. And it allows the partner really to sort of say, okay, I see this, right? I can see it and I can hold it and it's not me. And I feel like that does really create a safe space.
Thank you. I love that. It's not like It's not her fault. It's not his fault. It's not, there are really concrete things. And I had a patient the other day, she like cried with relief that, oh, there's reasons. Otherwise it was just this nebulous, cloudy, mysterious thing of, I don't want to have sex.
Yeah.
So it gave her hope, and she was really excited about that.
Yeah, that's very exciting. Oh, we could talk about this all day.
We could.
Yeah.
But
we got to come to
probably shouldn't.
Come to an end. We probably shouldn't. As always, if anyone wants to come see us, we're at True Women's Health, which is in Grand Rapids, Michigan. And you can check us out at truewomenshealth.com.
And we're very comfortable doing telehealth. Dr. Egan is also certified or licensed in other states. And
and we just added Florida today, which is very exciting to have a license in Florida, because we know that there's not a lot of doctors in Florida. And we also have a lot of patients that go to Florida. So we want to continue to be safe and provide care to meet women wherever they're at, maybe even in Florida.
Oh, we love it.
Yeah.
Cool. All right, everyone. Thank you so much. Be safe, be healthy, and live your truth.
All right. Have a good night.